Hi everyone, welcome to Vice Rounds about intussusceptions. I'm Dr. Whitney Phipps. I'm a small animal surgeon out in private practice, but I think it's really important that we keep educating you guys during this time when you can't be in the clinic, whether it's out rotations at private practices like ours or in your home university clinic. So I hope you and your educators find this helpful, and certainly feel free to reach out if I can answer any questions. So this is Nala. She's an 8-week-old female intact German Shepherd. She was adopted about 5 days ago, so the owners have pretty limited knowledge about her life so far. So she was treated with a quote-unquote all-natural dewormer by the breeder, but we don't know exactly what that means. And she received 1 round of the DHPP vaccine by the breeder's veterinarian. Nala initially presented to her RDBM with lethargy, vomiting, and diarrhea. So at this point, take a few minutes to list at least 5 differentials for Nala's clinical signs. You can write those down or take some time to discuss them in a group. So the big differentials for Nala are going to be intestinal parasites. Remember, intestinal parasites don't tend to cause a lot of illness in older dogs, but they can cause puppies to feel quite sick. Infectious gastroenteritis, such as parvovirus, is certainly possible, as well as non-infectious or kind of stress gastroenteritis. So we can often see sort of a shipping type disease in these dogs where they just get stressed as they're moved to their new home, and they develop some vomiting and diarrhea associated with that. Puppies can develop gastrointestinal obstruction. It's not all that common for them to develop a foreign body obstruction because their intestines are so distensible and they spend so much time kind of being supervised. But definitely it is possible. It's also possible if they could have an obstruction from an intussusception, or very rarely puppies can develop tumors as well. Again, not common, but certainly can be low on the list. She is a German Shepherd, so could she have something kind of inborn like exocrine pancreatic insufficiency potentially? And then any sort of dietary indiscretion or intolerance. So if she was able to get into the garbage at home and got into a toxin or something else that irritated her GI tract, or maybe she's recently switched to a new food that's causing her some GI distress. And then certainly there are extra GI causes as well, though that's going to be a little bit out of the scope of this particular topic. So Nala's referring veterinarian was pretty concerned about her, so she sent Nala over to our hospital. On physical exam, Nala was lethargic. We estimated that she was 5 to 7% dehydrated, and she had a palpable mass effect in her abdomen. She had a kind of stat blood panel, and these are her relevant findings there. So take a few minutes and either write down or discuss what physical exam findings would support an estimation of 5 to 7% dehydrated, and interpret the blood work findings. So remember, hydration status is really an estimation. It's based on a few physical exam findings, but there's kind of a continuum of signs that we're going to see. So I think it's important when you're estimating in your clinical record, a patient is 5 to 7% dehydrated. Also make quick note about what you mean by that, because that's going to really help make things clear between different veterinarians that are reading your records. So remember that dogs that are less than 5% dehydrated are probably not going to show any clinical signs associated with that. At 5 to 7% dehydrated, you're typically only going to see a subtle loss of skin elasticity. 7 to 10% dehydrated, you may see decreased skin turgor, a slight increase in capillary refill time, and the eyes may be sunken into the orbits. In an animal that's 10 to 12% dehydrated, you can have dry mucous membranes, a loss of skin turgor, sunken and dull eyes, as well as signs of shock, including tachycardia, difficulty maintaining your blood pressure. And then at 12 to 15% dehydrated, they're definitely going to be in hypovolemic shock, and death is really imminent if it's not corrected at that point. And Nala, based on her blood gas, was diagnosed with a hypochloremic metabolic alkalosis, which supports some type of gastrointestinal obstruction. So what diagnostic tests would you like to perform next? So go ahead and take a few minutes to either write those down or discuss them in your group. So for Nala, some diagnostics she had in the clinic were a fecal float. So again, like we talked about, these dogs can be pretty sick from GI parasites, and a fecal float is kind of a cage-side thing that you can do pretty quickly in your hospital. You can certainly also consider sending it out or sending it out for a Bayerman if you're worried about things that you may not pick up just on a float. Remember that your fecal test can have a false negative if the parasites aren't actively shedding at that time, so just something to keep in mind. It is also important that any puppy that's presenting with GI signs or any adult dog without a clear vaccination history is parvo tested. So Nala did have both a fecal float and a parvo test, and both were negative at the time of presentation to our hospital. And then you want to consider some kind of, so you should also have some sort of imaging on your list. Abdominal radiography is going to be the thing that most people are going to have access to in general practice, so that may be a place to start. But it's important to remember that puppies normally have decreased abdominal details, so radiographs may not be as rewarding, especially in such a young puppy. And just important not to overthink that decreased abdominal detail. So signs that can be consistent with an intestinal obstruction or intussusception on radiographs are going to be bowel loop distension. For an intussusception specifically, you may see a crescent sign, this kind of meniscus basically, that's really looking, it's really seeing the smaller loop of bowel invaginate into a larger loop of bowel. You may want to consider contrast studies if you're having difficulty figuring this out and you don't have access to an ultrasound. So barium swallows can certainly be considered. Remember, that's going to be contraindicated if you're worried that the dog might have an intestinal perforation. If you're concerned about an ileocecal colic intussusception, then you can consider doing a pneumocolonogram as well. So abdominal ultrasound is generally preferred to plain film radiographs for the diagnosis of intussusception in children, and is, like I said, probably going to be more rewarding than abdominal x-ray for puppies as well. What you're going to see in ultrasound is a target-like mass consisting of hyperechoic and hypoechoic concentric rings on the transverse section. So again, it's basically like looking kind of down a telescope as it's collapsing. You're going to be able to see those different rings as the loop of bowel is inside of another loop of bowel. So just a little bit on the anatomy and terminology while we're talking about imaging. So the intussusceptum is going to be the invaginated part of bowel that's telescoping into another loop of bowel, which is the intussusceptiens. So that's the enveloping segment of bowel. The invagination may be aboral, which is more common and means that the bowel is going in a normograde direction, or it can be oral, which means it's invaginating in a retrograde direction. So at this point, we have a diagnosis for Nala. We've diagnosed her intussusception on her abdominal ultrasound. So now we need to go talk to our client, let them know what's going on and kind of where we go from here. So client education is a huge part of getting owners on your team and helping them to feel like part of the decision, because they really are part of the decision about what's going to happen with their pet. So the first question a lot of people are going to have is, why is this happening to my dog? So you want to discuss breed predispositions and potential causes in an understandable way. And then how do we fix it? So you're going to discuss treatment options, and for Nala, what the overall goals of surgery are. Discuss the risks of surgery, so potential operative and post-operative risks. That's going to be really important for owners to understand, so that they are aware of potential complications that can happen. And then you want to talk about what else you can do. So cover their post-op and any long-term care that might be needed for their condition. So the pathophysiology of this disease is somewhat unclear. Mainly young animals are affected, although animals of any age can be affected. There is some predisposition. We do see this more commonly in German Shepherds, so something to think about, at least in Nala's case. There is thought that perhaps local intestinal incongruence and homogeneity, can contribute. So, if you have a smaller loop of bowel, it may be easier for it to telescope into a larger loop of bowel. And that may be why we tend to see this more commonly, like at the ileocecal colic junction, where you're having a relatively small ileum is able to telescope into the larger colon. There can be some mechanical linkage of non-adjacent intestinal segments, so a kink or a fold in the bowel wall, or it can happen as a sequela to intestinal parasitism, linear foreign bodies, nonspecific gastroenteritis, so really anything that is causing inflammation, diarrhea, straining, can lead to intussusception. Viral induced enteritis, such as parvovirus or distemper, as well as leptospirosis. Intraluminal masses can also contribute to intussusception. Again, that's going to be fairly rare in a puppy, but can still happen, and definitely something you want to think about if you see an intussusception in an older animal. And then any prior abdominal surgery can also potentially contribute to the development of an intussusception because it can cause adhesion formation. So for Nala, my big concerns for what could be causing this for her is, does she just have an underlying breed predisposition to this? Could she have intestinal parasitism since she hasn't really had, that we know of, an adequate deworming at this stage? Potentially she could have a foreign body that we don't know about before we get into surgery, although none was seen on her imaging. And then also, does she have just some kind of non-specific gastroenteritis? She's not used to her food yet. Maybe she's stressed. She has some diarrhea, and that kind of kicked everything off. So those were sort of my concerns for Nala specifically and what we talked with her owner about. So the next step is letting the client know what we do about this. And for an intussusception, it's going to be a surgical emergency. So just like any other form of GI obstruction, we want to get these guys to surgery when we want to get them stabilized, so volume resuscitated, and make sure they're as stable as possible to undergo anesthesia. But getting them into surgery quickly is really important because we do want to avoid them having a perforation and therefore septic abdomen. So options at surgery, we can sometimes just reduce the intussusception. There is a 25% recurrence rate with reduction alone. Typically, just reducing the intussusception is not going to be possible because there's going to be damage to the surrounding bowel wall, maybe the mesentery or mesenteric vessels. And so there is going to be some compromise, and a resection and anastomosis or RNA is required. With an RNA alone, there's about a 19% recurrence rate. So really important to talk to the owners that recurrence is potentially possible. The other thing that it is important to talk about is enteroplication, and there's definitely a lot of debate even between surgeons about when kind of enteroplication is the right choice for a pet. And so I'll talk about my approach to this and how I approach this in the clinical setting and also in terms of discussing it with owners. So enteroplication essentially means laying out the small intestines in kind of this accordion pattern like in the photo on the right. And then you just put intermittent sutures kind of between the layers of bowels, so that it stays kind of in this orientation. And the idea behind that is that it can help prevent the telescoping. The challenge is that there are potentially a lot of complications associated with enteroplication, and not all dogs are at risk for having a recurrent intussusception. So potential complications of enteroplication include abdominal discomfort, chronic vomiting and diarrhea, decreased appetite, constipation. They are at somewhat of an increased risk for foreign body obstruction because they do have these kind of hairpin turns at the edges. You try to make those as kind of sweeping as possible so they're not super tight hairpin turns, but there is still a risk that foreign bodies can get stuck there. Post-op volvulus has also been reported following enteroplication, although it's not clear if that's was truly related to enteroplication or some other predisposing factor. So I basically talk to owners about these potential complications, and for a first-time intussusception, I generally tell them if they want to really minimize the risk that they're going to have a recurrence, then we can enteroplicate, but I do stress to them that the risk of recurrence is really low, and there is a pretty significant risk of chronic complications with enteroplication, and I leave the decision up to them. Once you've had a dog that's had multiple intussusceptions, or maybe they have some cause of their intussusception that you're not going to be able to fix, then I really push more for enteroplication. But this is one where I really like the owners to understand what they're potentially getting into before we decide together if enteroplication is right for the dog. So take a few minutes to write down potential perioperative complications that Nala could encounter or discuss them with your group. So the complications that I discuss with Nala's owner include adverse anesthetic events. So, anytime we're putting a dog under anesthesia, there's always a risk that the dog can have an adverse reaction to the medication that we use. That risk is very low, and we do tend to use a lot of medications that are either rapidly metabolized by the body or they have a reversal agent. So that helps decrease the risk as well. There is always a risk of a negative explore. So anytime you're doing an abdominal procedure, it's important to let owners know you may not find exactly what you thought you saw on your preoperative diagnostics. And certainly with intussusceptions, they can have sliding intussusceptions that kind of spontaneously reduce. So you may get in there and not see that they have an active intussusception. Aspiration pneumonia is certainly a concern in a dog that's had a lot of vomiting. It's even possible that they could have aspirated prior to presentation to the hospital or while they're being volume resuscitated prior to surgery. And certainly when they're under anesthesia, there's a risk that they can aspirate secondary, to decrease protection of their airway and also to any nausea associated with their anesthetic medications. We can potentially see intestinal dehiscence. This is one of the most important things to talk to owners about before their dog undergoes gastrointestinal surgery. So the risk of that is really, really low, but it's there. And the most common time for it to happen is about 3 to 5 days after surgery. And for the vast majority of these guys, they're going to be home during that time. So it's really important that the owners know about this possibility and also know what they're going to be looking for. So obviously, if a dog starts leaking from their intestinal surgery site, that's going to lead to a septic abdomen and is going to cause them to have, to have a life-threatening infection and need additional emergency surgery. So really important for owners to know about. The things I tell owners to watch for at home are, vomiting, that their appetite is getting worse rather than better, that they're becoming more lethargic rather than less lethargic, and if they have a sudden increase in abdominal pain. All those are things that they need to be evaluated for. When we're talking about potentially doing a resection and anastomosis, which we may need to do for an intussusception, as we discussed, there is a risk of short bowel syndrome. So that's important that owners kind of understand that there's a risk for that, as well as skin incisional complications. Again, low risk, but there anytime we make an incision in the skin. So then I do like to talk to clients about what the postoperative care, both in the hospital and at home, is going to look like. I think it's really important for them to understand what we're going to be doing for their dog. For a lot of clients, their only experience with pets having surgery are, spays and neuters or maybe dentals, and so their dog goes home later that day. So they're not necessarily used to a dog being hospitalized for supportive care. So the reported mean hospitalization for intussusceptions is about 4.9 days, so almost 5 days. I think probably my experience of that is a little lower. I usually prep owners for about 2 to 3 days in the hospital, but I do tell them that it can kind of go up from there depending on how their pet responds to treatment. And I generally put a sort of vague timeline on it, and I really tell owners my big concern is for what our goals to go home are. And so for me, for Nala, her goals to go home are that she's comfortable on her oral pain meds, she's eating and drinking on her own, and she's not having any nausea and vomiting. The eating and drinking and keeping food and water down is really even more important when you're talking about dealing with a puppy, because they don't have as many nutritional stores. It's harder for them to maintain themselves if they're not eating and drinking on their own. So in terms of supportive care in the hospital, these guys are going to get IV fluids, pain control, GI support, and nutritional support. When they go home, they are likely going to go home with some at-home meds, at the very least pain medications, maybe antibiotics, depending on kind of our surgical findings, things like that. So I tend to tell owners that we'll limit medications at home to those that need to be given 2 to 3 times a day, and they can kind of manage those as breakfast time, dinner time, and bedtime if needed. I think that's pretty realistic for most owners. Doing much more than that becomes really challenging with people's daily lives. So they are going to have to be strictly rested for about 2 weeks after surgery. They'll need to be confined to a crate or small room without high surfaces when they're unsupervised. Go for leash walks only long enough to do their business. And I do kind of stress to clients that the dogs need to be on leash even in the yard. They do need to wear their e-collar for about 2 weeks and no bathing for 2 weeks. So Nala's owners decided they were a go for surgery. After a pretty long discussion with them about enteroplication, they decided to forego it at that point and in favor of kind of an aggressive deworming schedule and just trying to control her enteritis. So take a few minutes to write down an anesthetic plan or discuss one with your group for Nala and try to explain why you chose the medications that you did or maybe avoided some medications that you didn't choose. So for Nala, for her pre-medications, we went with hydromorphone and midazolam. An opioid and a benzodiazepine is really a reasonable choice for a puppy. You want to avoid things like dexmedetomidine because that's going to decrease their heart rate. And remember that puppies are really dependent on their heart rate to maintain their blood pressure. Using a full mu agonist is going to be really important for pain control in these guys. Hydro is a good choice. It's relatively inexpensive, although it does tend to make dogs a little more nauseated than something like methadone, which does come with a higher cost as well. For Nala, we induced her with propofol and maintained her anesthesia with a fentanyl CRI, and then the lowest concentration of isoflurane possible, although certainly sevoflurane would have been a reasonable option as well. So at surgery, we found a mid-jejunal intussusception with necrosis and marked damage to her jejunal vessels. We didn't find any obvious foreign material or parasites at surgery, and no other abnormalities in her abdomen. Her intussusception was pretty large, so she did have a resection and an anastomosis of approximately 25% of her jejunum. So now take a few minutes to write down or discuss with your group a postoperative plan for Nala. So for Nala, we put her on 120 mils per kg per day of a maintenance IV fluid. So we chose LRS, but certainly Plasmolite or Normar would be reasonable as well. Remember that puppies do have a higher maintenance requirement for fluid, so that's something you have to take into account when you're making your post-op plan. For pain control, I did use Nocita intraop with her. That's a pretty common thing I do with abdominal surgery because I do like to spare their opioids as much as possible. I think that helps decrease their post-op ileus and their kind of post-op inappetence and nausea as well. So for pain control, post-operatively, Nala got gabapentin, and then we pain scored her according to the CSU pain scale, Q4 hours, and rescued her with buprenorphine as needed. For GI support, we kept her on meropitant and pantoprazole until she was eating well on her own. And then we did also opt for nutritional support for her. So she had a nasogastric tube in place, and we started trickle feeding in a quarter RER as soon as she was kind of fully awake and not showing any signs of nausea. We also treated her underlying enteritis, so we dewormed her with Panacure and kept her on metronidazole and probiotics. And then really the big thing for her owner at home was to monitor for recurrence. So Nala started eating the day after surgery and was discharged about 3 days post-op when she was eating really consistently. And her diarrhea was a little better under control, so we could make sure she stayed hydrated at home. So she initially did well at home after discharge, but she was readmitted 6 days post-op because she seemed to be a little uncomfortable and had a single episode of vomiting, but her physical exam was otherwise unremarkable and her blood work was normal at that time. She responded to about 24 hours of IV fluids and treatment with Albon for potential coccidiosis. So that is a parasite in particular that tends to make puppies feel unwell. So sometimes treating them for that can help them kind of more fully bounce back. So Nala continued to do well for a few weeks after surgery, but then she represented to her referring veterinarian about 5 weeks after surgery, again with lethargy, anorexia, vomiting, hematochezia, and again had a palpable mass effect in her abdomen. And this is her ultrasound. We actually managed to catch her intussusception just on our ultrasound that we use for fast scanning in the ER. So we diagnosed her with a recurrent intussusception. And at this point, you know, it can always feel challenging as a veterinarian to know that, well, I didn't enteroplicate her, and maybe I should have. But again, the owner was really happy with the decisions that he made and was very understanding about this recurrence. And so I think a little preemptive client education and making sure they feel like part of the team can really help smooth over situations like this, when certainly all of us are disappointed that Nala is having a recurrence, but all know that we're just doing the best we can for her. So at surgery, she did have an ileocolic intussusception. So at that point, her ileum was resected and she had a jejunocolic anastomosis. In her kind of mid-jejunum, we could palpate a foreign body, or what we thought was a foreign body. But when we incised the serosa, we could actually see a second serosa. So basically what had happened was she had an intussusception there as well. And it was just so chronic and fibrosed that we couldn't reduce it. And that's why it felt like a foreign body. So at that point, she had a jejunal RNA as well. Because she had had so much abdominal surgery, we were worried about how many adhesions she might develop. So we went ahead and performed an ovariohysterectomy and a prophylactic gastropexy as well, just so that she wouldn't have to have those performed later, potentially in the face of a lot of adhesions. So take a few minutes to write down or discuss with your group some risk factors for short bowel syndrome and what clinical signs you expect to see with those. So our big concern for short bowel syndrome is really when we're resecting greater than 50% of the small intestine. And so at that point, that is definitely something that Nala had, because I had resected about 25% of her small intestine in her initial surgery, and then she had a bit more of her intestine removed at the second surgery as well. I do think that I tend to see more short bowel syndrome when the dogs have their entire ileum removed. So I think if we can try to confine our resection to just the jejunum and leave them some ileum, they're less likely to have short bowel syndrome even when we start approaching that 50%. But unfortunately, Nala's entire ileum was compromised by her intussusception, so she lost that as well. So Nala did have chronic diarrhea, which is pretty much the hallmark we see with short bowel syndrome. The owner described her stool as kind of thick gravy. So treatments for her included a vitamin B12 injection, metronidazole, omeprazole, and we switched her to a bland diet. We chose Purina EN because it is labeled for puppies as well. And then she's on probiotics chronically. She did develop a relationship with our nutritionist so that we could make sure that she was kind of maintaining her weight, and we could do everything we could to nutritionally support her kind of throughout her life. Other than her chronic diarrhea, Nala did very well post-operatively, and that was something that they were able to manage with her at home. Didn't have a lot of accidents in the house. They just knew they need to let her out frequently. So she went on to live a happy life. So I just wanted to mention a few other things about intussusceptions that didn't necessarily come up when speaking about Nala in particular. So certainly they can happen in other parts of the GI tract. As I said, the ileocecal junction is one of the more common areas. Nala also had a jejunal intussusception. We can also see gastroesophageal intussusceptions or colorectal intussusceptions. Gastroesophageal is thought to be caused by anatomic abnormalities such as esophageal hiatal enlargement, lower esophageal sphincter incompetency, or esophageal motility disorders, as well as potential increased abdominal pressure, so blunt trauma or negative intrathoracic pressure from inspiratory dyspnea. So this may be something that you see especially in brachycephalic dogs. Clinical signs associated with gastrointestinal intussusceptions include vomiting, regurgitation, hypersalivation, and dysphagia. You're not likely to see some of the diarrhea and hematochezia you often see with small intestinal intussusceptions. They may have concurrent respiratory distress because if they have a lot of their stomach in their thoracic area, they're going to have a really significant space-occupying intrathoracic mass effect, or they may have secondary aspiration pneumonia from all of their vomiting and regurgitation. It's also possible that they could have cardiovascular compromise from compression of their great vessels, causing decreased return of blood to their heart. Gastroesophageal intussusception is generally diagnosed on plain film radiographs. You may also need a barium contrast study, although remember, these dogs are at risk for increased aspiration. Fluoroscopy can also be especially useful for identifying esophageal dysmotility that may be associated with the gastroesophageal intussusception. So like we talked about, one of the biggest things that we see, that we use to diagnose intussusception is that target sign on abdominal ultrasound. It's important to remember that the target sign can have mimics. So just like with any diagnostic tool, you really need to use it in reference to the entire patient and all of your other diagnostics, your physical exam findings, and your history, and really put together a story that fits all of those things. So potentially healthy mimics that we can see include healthy intestine, postpartum involution of the uterus, although again, generally we're going to know that a pet just had puppies or kittens, and sometimes normal lymph nodes can have that target appearance. Pathologic mimics include any cause of bowel wall thickening, so inflammation, neoplasia, edema, or bleeding into the intestinal wall. Intestinal ascariasis or an area of volvulus can also have that target appearance. So we've talked a lot about dogs and intussusceptions, but cats can develop intussusceptions as well. It's most common in young cats, and again, the ileocolic area is most common, but it has been reported to be gastroesophageal, jejunal, ileojejunal, and colorectal. Predisposing factors may include intestinal foreign bodies, neoplasia, and parasitism. They have similar clinical signs to dogs, except that cats have vomiting and diarrhea less frequently. They tend to have more kind of lethargy and anorexia, as opposed to more overt GI signs. So thank you so much for attending my vice rounds. I really hope you enjoyed this clinical case. Certainly feel free to reach out with any questions. And in the meantime, take care of yourselves. Make sure you're practicing your social distancing. You're doing everything you can to protect your own health and the health of your family members. I do want to acknowledge kind of Slide Carnival and Flat Icon for the template and icons we used. Again, I'm Whitney Phipps. Please feel free to reach out with any questions. I do really want to thank Dr. Alex Fox Alvarez for spearheading Vice Rounds and making this awesome template. You know, he's really doing some great work for students, and we're all just happy to contribute.